Good morning. So we'll go on to our next session, which is titled Medical Management of Necrotizing Pancreatitis. I'm Dhiraj Yadav from the University of Pittsburgh, and with me is Dr. Yan B. from the Mayo Clinic in Jacksonville, Florida. We have 4 speakers in this session. Similar to the sessions earlier in the day, we'll have the talks first, and then we'll take questions at the end. Our first speaker is Dr. James Buxbaum, who's going to talk about the role of fluids in preventing necrotizing pancreatitis.
Thank you for the opportunity to speak today at the American Pancreas Association. It's a great honor. So the first question in this talk is, does fluid volume and type prevent necrosis? And the second thought is, does volume and type impact other adverse events associated with acute pancreatitis? And we're going to look at the theory, some observational studies, and then the randomized data, and think about the future in this area. So the theory about fluids and volume of fluids and necrotizing pancreatitis comes from animal models, looking at in vivo microscopy and oxygen tension. And what's seen is that pancreatic blood flow does decrease in the setting of acute pancreatitis. And importantly, regions of hypoperfusion do correlate with areas of more intense hemorrhagic necrosis, leading to this idea that maybe we can prevent the progression from interstitial into necrotic pancreatitis with fluid volume. And indeed, when there was randomized studies of animals looking at the administration of subcutaneous fluids, there was a correction of splanchnic perfusion abnormalities with greater amounts of volume for these animals. And then there's even dose-response curves looking at the amount of fluid administered in survival. Interestingly, when you looked at the histology, there was not a compelling difference in the severity of pancreatitis. There was, however, differences. There was less a decrease in hematocrit in those that got more fluids and increased survival. Which brings us to the next part as the controversial question of hemoconcentration and what it means in terms of identifying and managing hemorrhagic and necrotic pancreatitis. So early studies from Peter Banks's group really showed that it was a very strong marker, but then subsequent studies from Tim Gardner and others showed that the sensitivity was somewhat lower, although the specificity was maintained. And as this has evolved, it appears that in those patients who are primarily admitted for pancreatitis rather than those who are transferred into a major center, that hematocrit has a greater predictive power, positive predictive power. However, really, if you look across the studies, it's actually quite good specificity for necrosis and has a high negative predictive value. So this raises the question, is this a chicken or the egg phenomenon? Does the hematocrit show there's adequate perfusion and hence less necrosis? Or is it simply these patients don't have necrosis and hence necrosis itself might be causing the hemoconcentration? So not entirely clear. Similarly, creatinine has been proposed as a marker of necrosis. It does have a high odds ratio for the development. However, again, the sensitivity is lower while the specificity is high. So again, we see this phenomenon of having a high negative predictive value for necrosis without a strong positive predictive value. BUN has been studied with mortality, though not as much with necrosis, but likely the same concept. And so what we have is with hematocrit, BUN, creatinine, if they're normal, it's likely that the patient doesn't have necrosis, but they don't have as strong as a positive predictive role. And what that means in terms of fluid and necrosis is a bit controversial. Now, looking at the first kind of studies of administering a lot of fluids to patients, the Mayo Group and Tim Gardner have done a lot on this, and they've shown that the administration of more of the fluid earlier in the hospitalization is associated with better outcomes. There's less persistent SIRS, there's less organ failure, and the hospital stay is shorter. And it's quite analogous to Charles Baxter's Parkland formula, where you give a lot of lactated ringers in the first 8 hours for burn patients. It's sort of these golden hours, and also with trauma. And Beechin and others in this room conducted one of the first studies of goal-directed versus standard care, in which fluid was administered to achieve hydration goals versus just what was done in a standard way. Unfortunately, the two groups kind of merged with the same volume, and so the outcomes are comparable, but this was a good beginning of studying this area. Our group in LA County did a moderate versus aggressive trial with a little bit more enforced fluid volumes. And we did see that there was an earlier resumption of nutrition, resolution of biomarkers, and a quicker resolution of epigastric pain with greater hydration. However, we did not report necrosis, and this was also not reported by Beach and Wu's group either. If you want to get really aggressive with your fluids, you can be like Mao and all in China, and they kind of like an Oroville Dam situation where you're breaking and they were giving 1,000 cc's an hour. And there actually they may have gone over the other direction. There was more issues of things like compartment syndrome, a ventilator requirement, and less overall survival. But again, they also didn't report necrosis. So what the studies overall show, there appears to be some improvement with a moderately aggressive hydration approach, but the data really, whether this prevents necrosis in humans, is still lacking. So Enrique de Madar is leading the Waterfall trial, which is a multi-center national study looking at lactated ringers, aggressive versus a more moderate to assess for these outcomes, and they are using the modified Atlanta as their main outcome, and necrosis will be part of this. So I think this will inform this question more than what we currently have. So we'll move on to type. So classically in acute pancreatitis, the management was with normal saline, and as we've now very well established, this does cause higher levels of chloride and lower levels of bicarbonate. So it predictably does cause a non-GAP metabolic acidosis. And so there's a stronger interest in using more physiologic formulas, things that are closer to plasma. So lactated ringers is probably most common, but also plasmolite and a few other things. And the idea that this will cause less acidosis. Now in the ICU and now ER literature, there's been a debate whether the renal vasoconstriction, which can cause with high doses of saline, acidosis are problematic. There was a large trial in JAMA, the split trial, which didn't show any difference. However, when they went with two very large trials of 8,000 and 13,000 patients in the ICU and ER, there actually was an improvement with LR in terms of causing less major adverse renal events, things like the requirement for dialysis or CRRT. But so there is a difference with these fluids, but it does appear that you do need large numbers to show it. Now in pancreatitis, there's been a body of literature which does show that acidosis favors the development and progression of pancreatitis. You know, the general concepts that we know are that diabetic ketoacidosis and organic acidemias, such as with certain HIV drugs, can actually cause a pancreatitis. Part of the basic aspect is that it's known with lower pH that there's more calcium-mediated signaling in the pancreas. In vitro models with tissue cultures, it's known that trypsin activity increases as you lower the pH. And if you feed animals acid plus cerulean to cause a pancreatitis, you get a much bigger response with the acid model. So it's thought that lower extracellular pH will cause a progression of pancreatitis. There's also potentially an immune response, especially with lactate. It's known that in tissue cultures that lactic acid will stimulate an anti-inflammatory pattern of cytokines, whereas hydrochloric acid will stimulate more of a pro-inflammatory pattern. And in animal models of pancreatitis, it's been shown that the administration of lactate, in addition to cerulean, which causes the pancreatitis, can preserve the histology, so less severe histologic changes, less necrosis, but also a relatively lower amylase and tryptase for those that are receiving lactate. So there may be an immunoprotective effect, and this is thought to be mediated via one of the toll-like receptors in the GPR81, which you'll hear more about in this meeting, I'm sure. So how about the human study? So interestingly, when Beechin did a study of goal-directed therapy, he actually did a 2-by-2 model in which he actually then randomized to saline versus lactated ringers. And there was a much lower prevalence of SIRS in those who received lactated ringers at 24 hours than those who received saline. There was an 81% versus 0 reduction. So it's quite impressive, which did lead to other studies. However, de Madar et al. In Spain attempted to replicate it, and there was no real difference in SIRS at 24 hours. Whereas Chukasal in Thailand did try it as well, and then they did see this difference. So it's a bit of a debate. So at our group at LA County, we did a larger study of 120 patients, and we gave patients in both arms high rates of fluids on a controlled goal-directed paradigm using weight basing. And we compared it NS and LR. And we didn't see any difference in SIRS at 24, 48, or 72 hours. But what we did see, interestingly, is there was less ICU admission in those with LR, and there was less local complications, almost all of which were necrosis. So putting the data together in meta-analysis from all the randomized trials comparing saline and LR, which you can see there's no significant difference in SIRS. But you do have less moderately severe and severe pancreatitis. But this is driven almost entirely by differences in local complications and not organ failure. And in fact, there's a lower rate of necrosis with LR, looking at all the data pulled together. But again, this is not that many studies. This is a meta-analysis, so you need to be aware of all the pitfalls of that methodology. So putting it all together, for fluid volume, animal models, there is good evidence that lower perfusion regionally does correlate with necrosis. There's circumstantial evidence in terms of biomarkers with hematocrit and creatinine. If they are low, this tends to be a good negative predictor for necrosis. But is this a chicken or egg thing? Is it adequate hydration, or is it that necrosis causes hemoconcentration and elevated creatinine? It's not totally clear. And in the observational and very limited randomized data that we have, it does suggest that there's likely some type of favorable effect with aggressive hydration in terms of organ failure and symptoms and things of that nature, but really no evidence yet for necrosis, although the waterfall study may give this. For types of fluid, it appears that it's well known that lactate ringers and balanced fluids are less likely to cause acidosis. And in the sepsis and ICU and ER literature, the use of LR is associated with less need for renal replacement. In pancreatitis, this is of particular interest because low pH is associated again with pancreatitis and activation of trypsin and other zymogens, and lactate may have an anti-inflammatory effect. In randomized trials, it doesn't appear that there's a convincing difference in SIRS with LR versus NS, but there may be improvement in other outcomes, particularly local complications and possibly things like necrosis. So this creates an interesting thing in that volume and type of fluid may act in two different areas and help with pancreatitis in two ways. Theoretically, volume may reduce organ failure and may prevent renal insufficiency. There's no human data yet on necrosis, but maybe it doesn't even act on necrosis per se. It may work with the systemic manifestations. Where interestingly, LR does appear to possibly reduce local complications, possibly maybe some signal against necrosis. So maybe the type will impact the more local changes. So it'll be interesting to see how this plays out in upcoming studies of these two different areas, possibly working two different mechanisms of this disease. Interestingly, the current APA guidelines are in concert with this. They do recommend lactate ringers at least 5 cc's per hour to meet the parameters of hematocrit and urine output, greater than 0.5 cc's per hour. Thank you for your time.
Thank you. That's an excellent talk. Thank you. So our next speaker will be Dr. Santhi Veggie from Mayo Clinic in Rochester. He will talk with us about roles of antimicrobials in necrotizing pancreatitis. Thank you.
Thank you, Dheeraj. Thank you, Jan. Thank you, APA leadership. Good morning to everybody. So my talk today is antimicrobials in necrotizing pancreatitis. So disclosures, these are my disclosures, and I don't have any industry funding. But the only disclosure I have to make is I am a pure private practicing type of physician, so my talk is also going to be just like a private practitioner. The outline of my talk is background, the types of infection in acute pancreatitis, how to diagnose the infection, the microbiology, routes and different types of antimicrobials, efficacy in infected necrosis, the big event here, and the multi-drug resistant and fungal infection problems, and the take-home messages. So one thing important to know before the start of the talk is the costs and dangers of antimicrobials, which all of us are very familiar. $10.7 billion annually on antibiotics in the United States alone, 2009. 700 to 800 tons per year of antibiotics in the world, 15% in the hospitals, and then 700,000 lives lost per year due to superbugs, or the so-called multi-drug resistant organisms, MDRO, and $10 billion excess healthcare costs per year in the United States because of the antimicrobial resistance. So with that, the actual acute pancreatitis scenario is, it's an important cause of morbidity and mortality. Earlier, we used to say the mortality is as high as 30%, but it is coming down now. And it's mainly because of the altered gut mucosal barrier in acute pancreatitis, and then the bacteria that are present in the lumen of the gut, they just translocate through the wall into the necrotic tissues. And earlier we used to feel that in the first 2 weeks, the so-called phase 1 infections are not common, but in the last 2 decades, we know that infection can happen any time from day 1, and 25% of all infections can happen in the first phase, which is the first 2 weeks. And increasing gram-positive and fungal infections is a very important thing. About 20 years ago, we used to say that almost all are gut-derived gram-negative, but that's not the case anymore. If you look at the types of infections, the most important is the necrosis and the infected necrosis. That's where we put all our discussions about. In the first 2 weeks, the so-called phase 1, it is without a wall of these collections that get infected. And after the 2 weeks, it's phase 2, where a wall forms, so-called walled-off necrosis. But the extra pancreatic infections like pneumonia, bacteremia, urinary tract infection, line infections, cholangitis, those are pretty non-controversial. You treat them with the antimicrobials, and in cholangitis, you have to do urgent ERCP. But how do we diagnose the infected necrosis? Previously, the guidelines used to say you do FNA, CT-guided FNA of the necrosed area when you're suspecting infection and send gram stain and culture positivity. But in the recent decade, you see that all guidelines have given up on the FNA because it's rarely done. The only time it is done these days is when you suspect infection, send cultures, start antibiotics, and patients don't improve in the next 48, 72 hours, and they start deteriorating. Then you do CT-guided aspiration to see what bugs are there and what antibiotic susceptibility if you have to change your antibiotics. Gas in necrosis, as Bolan has mentioned, is very useful. It's seen in 30% at least of the patients with infected necrosis. I thought it was much less earlier, but recent NEJM paper by the Dutch group clearly shows 30% showed gas. After 14 days, that means when you enter into phase 2, that's when you can use these signs, that is a persistent organ failure, with 2 of the 3 things like fever, high CRP, and high WBC count. Why don't you use it before in the first 2 weeks? Because this simple SIRS without infection can also cause these things, and this is a very tricky situation in the first 7 days or 2 weeks. You know, whether these things really mean infection or not infection. But of course, when you have doubts and the patient is deteriorating, you have no choice. You have to treat it as infection. But this is where procalcitonin, several papers say that if you add procalcitonin when you're suspecting infection and without FNA proof that you want to give antibiotics, it may be useful. The indications for antibiotics in pancreatic necrosis is, these are all extra pancreatic, very non-controversial. But in the first week, this is a very difficult scenario that you all will face. You suspect infection, there is fever, there is CRP, there is WBC, but whether it is SIRS or not. But if the patient is doing badly, you have no choice. But if you start antibiotics and if they are not improving, then should you actually go in for the intervention in the first week or 2 weeks is extremely controversial. Subsequent, I think Guru probably is going to touch in the next intervention session on that. And after 2 to 4 weeks, infected walled-off necrosis is an indication for antimicrobials. Prophylactic antibiotics, which again were dropped in all the recent guidelines, but used to be in all previous guidelines. What are prophylactic antibiotics? That is, in the first 24 to 72 hours, when you use any predicting system to say that this patient is going to develop moderately severe or severe pancreatitis, giving them antibiotics without infection, with the goal that you will prevent an infected necrosis, which is to be avoided. That's prophylactic antibiotic. But more recent studies and meta-analysis have shown that they are of no use. Earlier studies and meta-analysis showed that they are of use. When we did the technical review for AGA, which was published in 2018 in Gastroenterology, we looked at all the studies, and when we looked at all the studies, including recent and the past studies, there is some trend for the mortality reduction and infection reduction, but it's not very significant. People still feel there may be subgroups where you can give prophylactic antibiotics, like extensive organ failure and necrosis, But the problem is, can a large study be done to show that this subgroup gets benefited? I don't think so. And hence all the new guidelines say no prophylactic antibiotics. So the microbiology is the next thing that we need to know. So as you can see from this slide, the gram-positives, that is staph and enterococci and C. diff, are the predominant ones, and the gram-negative, E. coli and Pseudomonas, are coming down. This is based on 10,000 patients Hungarian meta-analysis study. Fungi are usually Candida albicans, but occasionally you can get Candida tropicalis as well as Candida krusei. But one word about multi-drug resistant organisms, which is extremely important because CDC has made a call to all of us in 2019 that this is a big problem because we use antibiotics so frequently, and they divided it into urgent, serious, and concerning threats. So we need to be aware of that. And some of them you already know. Carbapenem-resistant enterococci, carbapenem-resistant Acinetobacterus, vancomycin-resistant enterococci, MRSA, and extended-spectrum beta-lactamase inhibitors. These are the bugs that are going to be the big problem for human living in the coming years. So next is the route of antibiotics we use. Intravenous, usually antibiotics which have good pancreatic penetration. Carbapenems, piperacillin, tazobactam, that is zosyn, metronidazole, third-generation cephalosporins, and quinolones. But quinolones are being almost not used because of increasing problem with bad C. diff, QT prolongation, tendon rupture, so on and so forth. But in our own institution, because of the antibiotic stewardship, and you have to reserve carbapenems for really bad infections, zosyn, that is piperacillin tazobactam, is what our infectious diseases committee advises us to use. Intra-arterial antibiotics, almost all the studies are from Japan and eastern half. They are not replicated in the western half, and almost all of them, the antibiotic into the abdominal arteries is given with protease inhibitors like nefomostat or gabaxate, and there is a lot of methodological problems with these studies. John Windsor has written a very good critical commentary, and that's the reason they are not reported from the West at all. And the thing, selective decontamination of the gut, once again, in the last 20 years, there are no studies. This is where you give oral colistin, norfloxacin, and amphotericin and sterilize the gut so that there are no bacteria to get translocated. Obviously, we don't have to worry about intra-arterial and selective decontamination, and it's almost always intravenous. And one word about antifungals. The fungal infection is becoming extremely common in infected necrosis, greater than 50% in some studies. There is no role for prophylactic antifungals when you start off antibiotics when you're suspecting infection. And these fungal organisms definitely cause increased morbidity, and there's a good review written by Guru along with me some time ago on this particular thing. And the agents here that we use, we have to be really on our toes to keep up with this. So many new antifungals coming. It's very, very difficult. For example, azoles, we know fluconazole, itraconazole, but now voriconazole, posaconazole, and isuvaconazole have come. Echinocandins, the caspone micafungin, and of course the time-trusted amphotericin B, but now in the liposomal and lipid complex format. The meta-analysis from the Hungarian pancreatitis group showed 10,000 patients from 22 countries and about 1,000 from their own registry. No consensus on starting antibiotics in people with no cultures. So people are doing whatever they like. 60% of all patients with acute pancreatitis got antibiotics, and 90% of them in the first 3 days. Clinicians depended more on elevated CRP, WBC, amylase, lipase, but none of them have any association with proven infection subsequently. And procalcitonin, they clearly found is going to be useful, and gram-positive bugs are becoming more common. And this is the latest hot-off-the-shelf paper by the Dutch group again, like many of their papers, where the immediate versus postponed intervention for infected necrotizing pancreatitis. And I only put this thing because we are not talking about interventions, but antibiotics. There are a few things that came up here. The mortality even in infected necrosis now is only about 10 to 13%. That's a good thing. Second thing is 30% of these patients will show gas on CT, so very useful sign. And the third thing is, even in this study, the earliest, or actually the median, where they actually diagnosed infected necrosis is about 22 to 23 days. So they have not found anyone in the first couple of weeks. So lastly, no talk is complete without COVID, and so many COVID and acute pancreatitis have been reported, but in the United States, out of 12,000 hospitalized patients, only 0.27% acute pancreatitis. This is because of the ACE receptor, 2 receptor that is present in the pancreatic duct, acinar and islet cells, which is important to for the uptake of the coronavirus, isolation of the virus from pseudocysts. But Enrique de Madaria, whom you know from Alicante, Spain, has done a beautiful analysis, Bradford Hill causality criteria framework. And according to this, he said there is no causality, it's just an association. And these are the drugs you know, remdesivir and the monoclonal antibody, and the new one that's going to be approved probably in the next few weeks for the oral. But these are for non-hospitalized patients, molnupiravir. Okay, this is the time point. So from day 0 to 4 weeks, extra pancreatic anytime you treat with antibiotics. First 24 hours, we are actually depending more on the prediction of severity, etiology, IV hydration. And from 72 hours to 14 days is where you have suspected infection, controversial how to diagnose, etc. The necrosis gets confirmed around 5 days or so. Enteral nutrition role comes at 5 days. And after 14 days is when you have walled-off necrosis. But the important thing is 40% of infected necrosis can be treated just with antibiotics alone without intervention. That's the Dutch study shows. So take-home points quickly. Infection, more mortality and morbidity, no role for prophylactic antibiotics. Gas on CT is seen in third. And FNA is very rarely done under some circumstances. After 2 weeks, if you have fever, CRP, WBC, procalcitonin, you can think about this particular thing. 40% of infected necrosis cured by antibiotics alone. These are the antibiotics that you can use with good pancreatic penetration. No response, catheter drainage, early phase, step-up endoscopic therapy, late stage. And lastly, when anybody who is using antibiotics has to be very, very aware and have the antibiotic stewardship. Thank you.
Thank you, Dr. Vege. Our next speaker is going to be Dr. Chris Worshmark, who's going to talk about pancreatic necrosis and the role of nutrition.
Thanks to the organizers. It is really nice to see people's faces after all this time. I know I feel a little bit unsettled about it, but I'm getting used to it now. All right, so I was going to talk about fitting in a theme, the role of nutrition in these patients with severe necrotizing pancreatitis. My talk's going to be outlined first just reminding us of some of the hypotheses and considerations upon which we base our approach to nutritional therapy, some review of what might be potential benefits of nutrition, and we'll talk about some of the outcomes that are listed there, some of the standard ones like mortality and necrosis, but also potentially prevention of certain complications. You've heard a lot about gut barrier function already. And then review sort of based on a number of guidelines, what the current strategy is. Think a little bit about some of the long-term nutritional issues which we don't commonly consider, and then just a review of some of the big unanswered questions. So providing nutrition to patients with acute pancreatitis hasn't changed a lot perhaps over the last 50 years. And these are some of the hypotheses that sort of have guided our choice. The first, I think we would probably agree that the vast majority of patients with mild or moderate acute pancreatitis don't need any nutritional intervention. They are able to eat on their own within a few days. It's really in the folks with severe pancreatitis where we're much more worried about them, at least from a nutritional perspective, and they're in negative nitrogen balance. So this is the group we're probably going to focus our strategies on. There has been a sense, I think, again, for decades that if we can provide nutrition while still not stimulating the pancreas, that might be beneficial to certain outcomes, and I'll review the data on that with you. There's also been this long-standing conception that the intestinal barrier function is disrupted in patients with acute pancreatitis, and that might lead to risks of infected pancreatic necrosis, and perhaps if we provided enteral nutrition, we could fix that problem. And then lastly, I'll just talk about exocrine pancreatic insufficiency, which is common in these patients and often, I think, not considered. So the first question or one of the early questions on that list of hypotheses is that we need to rest the pancreas. And so that's been led to a fear, I think, of delivering nutrients into the duodenum because we know, at least in normals, and that's the data on the top, that if you deliver nutrients to the duodenum, you stimulate pancreatic secretion, and if you deliver it to the jejunum, you do not. And that was the origin of all of our efforts at nasojejunal feeding. But if you actually look at the data in patients with pancreatitis, the gland is not really sensitive to stimulation by nutrients in the duodenum. So there's no evidence from this that whether you put nutrients in the duodenum or not, you're actually going to stimulate the gland. The second sort of, at least potential benefit we talk about a lot is gut barrier function. And the left is just sort of an analysis of patients with severe acute pancreatitis, looking at the proportion that have abnormal gut barrier function. And you can see it's in the neighborhood of 60% or so. So many of them have an abnormal gut barrier function. And the question is, if you put them on enteral nutrition, do you fix that? And there are a number of small randomized trials with different types of outcomes, but the bottom line, I think, is that there's no consensus in the data that providing enteral nutrition actually improves gut barrier function. So we have these hypotheses upon which we base our strategies, but the evidence supporting them is pretty limited. So from that, I'll move to sort of our actual strategy in terms of what are our options. When I was a fellow, you kept them NPO till they could eat, and then you gave them clear liquids, and when they could tolerate clear liquids, and you gradually advanced them to solid food. And then obviously we went to TPN, and then we said TPN is risky, so we went to nasojejunal tube feeding on the lower right there, and we said, well, maybe we can just put it in the duodenum with a simple cork tract tube in the middle, and maybe we can just do an NG tube. And now we're coming back to the same part where we started, which is maybe they can just eat. So the first question as we think about nutritional supplementation is who should get it? So we know that around 1 in 5, maybe 1 in 4 patients with acute pancreatitis will get severe disease or predicted to have severe disease. We know from the Python trial that about 70% of those people will be able to eat if you just wait a few days. So by my calculation, that says only about 6% of patients with pancreatitis actually need tube feeding. We know from a lot of data that enteral nutrition is superior to parenteral in many outcomes. The upper right is just a meta-analysis of randomized trials looking at overall infections. And there are small numbers of trials in the various combinations, but the bottom line is that enteral has fewer total infections and fewer pancreatic infections. And from the work that I did on that gastro technical review with Santhi and others, also less organ system failure, and a trend at least towards lower mortality. So we know that we should do it in the patients that are likely to get sick. We know that enteral is better than parenteral. We also know that adherence to just that simple fact is rather poor, at least in the US, and that is that a lot of patients with acute pancreatitis still get parenteral nutrition. These are just two studies on the left looking at patients transferred to tertiary care hospitals where a significant proportion showed up on TPN. And on the right, a survey of GI docs and PCPs in the US where 43% of them said they utilize TPN in managing acute pancreatitis. So this is the same kind of data holds for antibiotic use and that kind of stuff. So although we know enteral is better than parenteral, we often don't actually follow our own data. So then how? Obviously, if they can eat, you can let them eat, and if not, where should you put the tube? Again, there has been this idea that we have to deliver nutrients to the jejunum to minimize pancreatic stimulation, but actually it doesn't make any difference where the tube is. And if it doesn't make any difference where the tube is, you can imagine then just letting them eat might be the simplest way to do this, although this is based on a relatively small number of randomized trials. So what about what? What should we be feeding? Again, we have some randomized trials which have compared polymeric formulas like Ensure to semi-elemental or elemental formulas. They don't appear to make any difference in terms of the outcome of patients, in terms of the important outcomes, mortality, necrosis, infectious, stuff like that. There is data that once patients are ready to eat, if you just give them a solid low-fat diet instead of the clear liquid and then ratcheting up, you can save a couple of days of hospitalization, so that's pretty clear. And then there are some strategies using, different types of formulas, so-called immunonutrition, where you're adding stuff to it. And a number of small trials haven't really shown any important outcome, with the exception, of course, of the Propatria trial, which was not specifically a study of nutrition. It was a study of adding multiple species probiotic, but that demonstrated an increased mortality with the use of that particular probiotic combination for reasons that are still, I think, a little bit obscure. So it doesn't appear that you have to go to specialized formulas. It looks like a polymeric formula, which is the cheapest, is equally effective. And then the question is when. And so, there have been, you've heard a little bit about this goulash trial, which is trying to provide very high levels of calories and nutrient supplementation very early in the course to try to provide a source for ATP generation in the pancreas and hopefully prevent necrosis or necroptosis or ferroptosis or one of those optosis things we heard about this morning. And so we do have some randomized trials which have kind of looked at early versus late in severe pancreatitis. The slide on the left is from a meta-analysis. The two lower bars are patients with severe pancreatitis, and that's looking at mortality. And you can see there are wide error bars there. But this is not statistically improved. And there is some data from some trials looking at length of stay in severe pancreatitis as to whether early nutrition gets patients out of the hospital faster. And the data, at least from that we have it, is that it does not actually achieve that. It doesn't shorten length of stay. It is clear in folks that have mild to moderate acute pancreatitis, though, that if you don't keep them NPO for prolonged periods of time and sort of give them access to food essentially from when they're admitted, you can actually shorten length of stay, and that's the data on the right. So in terms of severe pancreatitis, if you're thinking about that group as potentially being fed with tubes, starting the tube feeding early versus a little bit later doesn't appear to make any difference in terms of outcome. In those with mild pancreatitis, which is the majority of our patients, the data says that we should let them eat as soon as they feel like eating, and there's no point in delaying it. And of course, the best data from when comes from the Dutch study, and you all have seen this data, but this was a strategy of putting a tube down as quickly as possible, starting tube feedings, versus letting the patient sit for the first 3 days, and then on day 4 and day 5 asking them if they wanted to eat. And by the time they hit day 5, if they still didn't want to eat, then they got a tube. So that's the strategy. And from this trial, you can see that there was really no difference in outcomes, no difference in mortality, no difference in necrosis, no difference in need for ICU admission, no difference in infected necrosis. There was a little bit of a delay in getting up to caloric goals. But other than that, really no difference. And interestingly, if you can see that number right there, about 70% of them started to eat within that 4 to 5 day period. It did not require a tube at all. So we have a lot of guidelines. This is just a list of many of the recent guidelines in terms of what should be our strategy for feeding these folks. And I just sort of hit the high points. One is all of the guidelines say you can use whatever you choose to use for a nutritional supplement through a tube, or just let them eat. They all say avoid TPN. They all say if they're able to eat, go ahead and let them eat at any time in the time course. They all say if you have to use a tube, it doesn't matter what kind of tube you use. And they have various time points that they recommend you start nutrition, either offering oral diet or or starting tube feeding. But again, the data from the Dutch study would suggest you don't have to do it immediately. It doesn't make any difference in terms of outcomes. The only point I wanted to make with this slide is that, and something we don't think about a lot, is a lot of these patients will develop exocrine insufficiency, and it can persist. And on the left is some data looking at the pooled prevalence of exocrine insufficiency for severe pancreatitis in the red bar, mild pancreatitis in the blue bar, and on the right is just a plot of looking at the relative risk of having exocrine insufficiency in edematous versus necrotizing pancreatitis. You can see at the bottom it's about a twofold increase. So the more severe the disease, the more likely is a patient to develop exocrine insufficiency and have it persist. But even those with milder forms of pancreatitis can have this outcome, and it can persist. So as I summarize the data, I guess this would be it. Avoid TPN. You don't have to make everyone NPO. You should initiate a solid low-fat diet when the patient's willing to eat. You can initiate tube feeding using any tube and any formula if they're not able to eat after 3 or 4 or 5 days, whatever is sort of your hospital strategy. Don't use probiotics, and consider the need for enzyme replacement therapy in these folks at the time of discharge, probably. I think there are some unknowns still. One of the big ones is implementation research. If we know what the right thing to do is and we don't do it, why don't we do it? So can we figure out ways to improve adherence to best practices? I think there's still some work to be done on whether specific additions to the diet might modulate the microbiome in such a way that would be beneficial. That's one thing to think about. There is still some argument as to whether this very early approach, providing massive amounts of calories from sort of the first few hours, the goulash approach will have some benefit in terms of stabilizing or preventing pancreatic necrosis. Don't forget about exocrine pancreatic insufficiency, and I think there's a lot of work that can be done in terms of healthcare economics, just utilization and costs for a nutritional strategy. So thanks. My manatee on the upper right hopefully will be able to take his mask off soon. Thanks.
Thank you, Dr. Worshmark. Our next speaker is Dr. Abu El Haji from Cincinnati Children's Hospital. She will talk about management of acute pancreatitis in children.
Good morning still. I would like to start by thanking the organizers for inviting me to be here and speak with you today on a broad topic that is dear to my heart, the management of acute pancreatitis in children. Through this talk, you would hear that I would touch on many of the talks that were presented earlier and some of what would be presented later. I have nothing to disclose. So from earlier studies in probably the last 2 decades, we learned a lot about pancreatitis in children. I show here a study done at the University of Pittsburgh Medical Center when Dr. Morinville was doing her rotation there. While the catchment population remained stable during that time, the incidence of acute pancreatitis was on the rise from 2 per 100,000 up to 13 per 100,000. From another single center data, and that's our own data at Cincinnati Children's, this is the total admissions of acute pancreatitis that I was just putting together in preparation for a grant submission. And it does show that it's probably there's a similar trend even on single institutions. Nationally, we utilize the Pediatric Health Information System, which is a database that is mostly a billing diagnosis database. While we know some of the limitations of those databases, it does capture 47 major children's hospitals, and it did show that acute pancreatitis over the decade that I show, from 2004 up to 2014, was indeed on the rise compared to all pediatric admissions from any cause. What we know about on acute pancreatitis management today is that you start by confirming that the patient actually meets the diagnosis criteria. Similar to the adult criteria, we do have 2 out of the 3 criteria. And then you assess the patient at the time of presentation. We do apply models for severity prediction, and I will show some of those through my talk today. And the reason is that you want to be able to triage the patient or maybe transfer them to a higher acuity facility or a tertiary care center if they need that ICU intensive management. In terms of fluids, there are some data that shows in children as well that aggressive and goal-directed hydration without having the actual randomized studies. I will walk you through some of the observational studies that we had, and it's really coded as 1.5 to 2 times maintenance per body weight is associated with better outcomes, and typically that's within the first day. Allowing early feeds, usually, or nutrition, so basically allowing the patients to take in PO within the first day or 3 days, and then watching for the symptoms progression and their laboratory and organ systems, and then pain control and analgesia. Some of the earliest studies that we started with where we wanted to change the culture of keeping the patients in PO. And I wanted to start by assessing, is early feeds a feasible thing in children? So we demonstrated through the small observational cohort study that included a nutritional prospective database that early nutrition was safe, feasible, and was not associated with adverse outcomes or adverse pain events. Actually, the patients who were allowed to PO on their own compared to the patients who were kept NPO by providers' orders had similar pain scores. And we also show, as I show in the figure in the bottom, that the higher fat intake was actually associated with lower pain scores. So the patients self-regulated themselves to advance. The higher fat intake was not associated with an increased length of stay, and as you may have imagined, the ones who were allowed to eat PO earlier left the hospital earlier. It begs the question, is a low-fat diet needed in acute pancreatitis, at least in the children cohort? And from there, we had a survey on the management, and I'm not going to show the results of that. It was only applied at our institution. It's a 750-bed hospital. So the people who manage pancreatitis are all different subspecialists, but mostly GI and hospitalist medicine. And from there, we surveyed people on their management, and we found that the results were variable. So it called for an action, and this was a quality improvement initiative where we built an admission order set to manage pancreatitis through EPIC, which is our EMR order system. The beauty of this is that you can standardize across institutions, you can share it with other institutions, you actually could put teaching points in red as I show here. And for nutrition, we defaulted to start clear liquid diet on admission, and within 6 hours you could let the patient advance to regular diet for age. And for IV fluids, using isotonic solution at 1.5 to 2 times maintenance. And QI could actually be converted to research. So while it was applied for a quality improvement January 2014, after a 1-year usage rate, we wanted to ensure that we're not harming the patients by the standardized protocol. So we looked at the 5 years prior and the 1 year after the order set. And as you recall, the order set wants you to use IV fluids at a higher rate and early nutrition. So if you take those measurements into account, you could end up with 4 groups. The purple group is the early PO and aggressive fluid management, and that's if they followed the order set. We had 96 in that group. The early PO and low IV fluids is 55. NPO high IV fluids is the red group, and we had 30, and then NPO and low IV fluids. Now, the order set was kind of categorized as such, whether that was at the time of order set or even prior to that. This is the treatment intervention. And the severe acute pancreatitis was 35% in the NPO and low IV fluid group compared to 4%, as you see low here, in the ones that were fed early and had aggressive fluid management. How about the type of fluid? And I had the pleasure to work with Dr. Peter Farrell through his fellowship, and we started by looking at the FIS database, and he really queried the database and found 15,000 acute pancreatitis admissions during the era that we looked at, and we really standardized it to 5 years post the APA guidelines to see, is really LR use more popular in children? And he had 111 in the LR group and almost 14,000 in the NS group. So the LR was actually associated with a lower length of stay, and they had a lower infection rate, lower TPN usage, lower cost of admission. These studies, with their limitation, just helps us maybe make hypothesis to get more granular studies in place. And from there, he just finished, actually, a randomized controlled trial. It was a multi-center study, and the main site is Cincinnati, and randomized 40 patients in each arm, LR versus normal saline, as a goal-directed aggressive fluid management, and the data analysis is ongoing right now. There is a new classification of acute pancreatitis, and we thought that all the studies that preceded that time, which was in 2017 when we came up with this classification, really was not comparing apples to apples, so we had to define it. And we partnered with the adult group, including Dr. Banks and Dr. Darwin Conwell, and it was under the NASPGHAN Pancreas Committee. And we came up, as you can see, probably with similar definitions to what is used in adults, but we had to utilize pediatric-based SIRS criteria and multi-organ failure criteria. So it does happen in children, and it's about 15 to 30% if you include the local pancreatic complications. So it is kind of more commonly seen than what we think. So children actually do have significant morbidity if they have acute pancreatitis. And I show here is that the red area represents intrapancreatic and peripancreatic necrosis in a pediatric patient. And then the imaging follow-up after that, it's just few days later, and that patient was really sick. Dr. Andrew Trout led an effort under the NASPGHAN Pancreas Committee, actually partnered with different pediatric pancreatologists and medical pancreatologists, and we had to come up with some definitions or what is the role of imaging in management of pancreatitis. And when it came to acute pancreatitis, we found that there is a role for ultrasound being as the first imaging modality, and then the CT or MRI are kind of reserved for local or delayed complications that you look at. So if the patient is not improving within 3 to 4 days, then you obtain those. But they're also useful for localizing or assessing if we need an intervention later. From the same NASPGHAN committee, we had come up with a management and a clinical guideline report, and I encourage all of you who manage pediatric patients and probably asked to assist in the management to go back to it. And it's basically just simplifying all the literature that we know, whether there's limited data in children, but also from the adults, and how it applies to children in the management. So then after all these guidelines, NASPGHAN guidelines, EPC guidelines, AGA and APA guidelines, we thought that maybe we need to revise our own order set. And we learned that we had different institutions who have order set. So Dr. Sellers from Stanford led this effort, and we partnered with Seattle and Iowa and Cincinnati Children's, and actually came up with something better than a guideline, and it became more like an algorithm. So if your patient is you're starting nutrition and they cannot tolerate it, what would you consider? The same thing for IV fluids. It's not like a one-size-fits-all. It's more you start with a bolus, and when you do you consider repetition? And pain management in that paper is also more extensive. Some of the knowledge gaps are basically that acute pancreatitis studies that we have or we had for the longest time were single-centered and retrospective, so made it difficult for us to predict who's going to have severe or recurrent pancreatitis. So we took on the effort in 2013 and designed the Acute Pancreatitis Registry at Cincinnati Children's. And I'll walk you here quickly through the design, which basically involves enrolling the patient during their index admission, collecting clinical variables that could predict the severity, and also we collect all the management elements and see what was the management outcome. We see the patients at 3 months and then 1 year after. That helped us get nutritional, exocrine, and endocrine-related data, which is kind of shocking to know that about 30%, I'm gonna steal your water, maybe. Did you drink from it, though? No, I did not. Okay. I have to check myself for polydipsia, yeah. So then from there, we are finding 25 to 30% with pre-diabetes or diabetes at 3 months and annual after a single attack. From the registry, we had genetic studies coming, biomarker studies, and then stool microbiome studies, patient-reported outcome studies. The beauty of this registry is that it was really a partnership between adult colleagues, like Dr. Papachristou, because we didn't want to do pediatric studies that could not be merged to show us what is the adult future like. And then actually, if you design them similar, like PAPI, you could merge results in the future more seamlessly. Dr. Vitale, through his fellowship, wanted to use the registry to look at what are the clinical biomarkers or clinical factors and laboratory factors that predict progression to severity. And he looked at all the available data that we had within 24 hours to predict which patients would progress to severe later. And actually, blood urea nitrogen, as a single marker, had an area under the receiver operating curve of 0.75. We also wanted to study the role of mixed metalloproteinases as endopeptidases that are involved in tissue healing and remodeling, and their tissue inhibitors. And we know there are 23 identified MMPs and 4 TIMs from a research standpoint to see how could we improve our prediction. And this is a nice exercise that Dr. Vitale did, and he showed through the classification and regression tree, which is CART methodology, that if you combine MMP 12 level and TIM 2, which is inhibitor 2, with the BUN, his model had a higher sensitivity and higher negative predictive value. Specificity also improved, and the area under the receiver operating curve was 0.89. More on novel biomarkers in severe acute pancreatitis. This project was done with the Stanford group, mainly Elena Jones and Aida Habtizian's lab, and we looked at subjects with they actually had all a similar presentation on admission, and then they progressed later to either continue to be mild or have moderately severe or severe pancreatitis. And we had a derivation and validation cohort. We used 2 different cytoplex assays, the Luminix platform. The first one had 62 markers, and the second one had 76 markers with some overlap. And we show here, and it's hard to see in this font, that IL-6 and the MCP-1 were both elevated in the group that progressed to severe. And here is more kind of a quantification measure, because for the severe, we combined moderately severe and severe together, and that was true in terms of IL-6 and MCP-1 elevation in derivation and the validation. Medications had taken a lot of interest from us in acute pancreatitis. Dr. Hussein's group, when he was at Yale actually in 2010, showed that medications play a significant role in the etiologies of pancreatitis. But if you look at the pie graph here, there's so many other etiologies beyond alcohol and gallstone of acute pancreatitis in children. So we have to look at all of those. And then I partnered with him a decade later, we still work together, to look at drug-induced pancreatitis in the Cincinnati cohort. And we found that it was present in 24%, and it was the leading cause of acute pancreatitis and index admissions. What I would like to show here is that it was in 10% drugs with another cause. What we also saw through this drug-induced pancreatic injury, if you want to say, the 40 subjects who had DIPI, drug-induced pancreatic injury, compared to the subject that did not have drugs to be involved, they were 125. DIPI had a moderately severe and severe course more likely. They had an ICU length and higher length of stay. Most of these were necrosis. What is after the acute pancreatitis? We're interested in endocrine components, exocrine components, quality of life, because all of these could be affected. So I'm just going to comment on the diabetes. We found about 25% of patients to have prediabetes or diabetes post-acute pancreatitis. 15% were actually after a single attack, 47% after the second attack, and then the rest after CP. Some of the data that we learned from this, when we looked at 52 subjects and only 13 of them had abnormal testing, and now we have more, that the higher age at the time of attack was associated with diabetes risk, and also having a higher BMI percentile, and having severe acute pancreatitis prior to the episode. This is a patient that should be watched in clinic. We actually watch all patients in clinic, because we still don't know how this disease goes at 3 months and 1 year. So necrosis was one of the biggest drivers. Some of the genetic data that we have from this CFTR, really, as I show in this heat map, I'm not going to go through it in details, the CFTR variants that were involved in the abnormal diabetes testing group were significantly different from the CFTR variants that were involved in the normal diabetes testing group. So it begs the question, does CFTR even is a risk factor for developing diabetes after a single attack? In terms of more on the genetics and what we learned from first attack, they do have a role to help us understand the progression of disease. Here, from a research standpoint, we tested 8 genes that I show here by next-generation sequencing, and then Sanger confirmed the findings in patients who had a first attack that we followed them. Half of those patients had acute recurrent and chronic pancreatitis, so we wanted to see the ones who did not develop recurrence. If we tested that cohort and the cohort that developed recurrence, what is the difference? And what we found is that having more genes is worse than having one gene or no genes in terms of progression to CP. But also the etiology of the first attack dictates the progression to CP over time. This is a Kaplan-Meier survival curve that shows that the highest progression was in the genetic, followed by the idiopathic group. And if you ask me, these will be genetics maybe a few years later. So I would conclude that pancreatitis is emerging in children. A subset would progress to a complicated course with severe course or diabetes or recurrence or chronic pancreatitis. The conditions that affect the pancreas in children are unique and require pancreatology expertise, mostly from a pediatric subspecialist. And acute pancreatitis is really advancing in the management through different research efforts. Precision medicine approaches are really suitably applied in children before environmental factors take effect. My next set goal of the 5 to 10 next years is really to summarize different data that I showed you through machine learning approaches and the genetics and the biomarkers to see what can we learn from merging all of this together. And this is my last slide. I would say, also the future is in our children. These are all kids that I had the honor to serve, and they all have one thing in common, which is childhood pancreatitis. Thank you for your time.
Thank you, Mason. Just stay here, and I'll request the other speakers also to please come on the podium. We have a good 20 minutes left for the session for discussion and questions. Go ahead, David.
I was waiting for Dr. Buxbaum to sit down and get ready to go because my question is for him. So, excellent talk, a very important area. 2 major questions. The first one is that there are studies of normal saline versus lactated ringers. And the question is it the chloride, is it the lactate? Does the lactate interfere with your measure of serum lactate that might be associated with ischemia and anaerobic metabolism? Has anybody looked at Plasma-Lite, which uses sodium acetate instead of sodium lactate? And secondly, there's a difference in whether or not the lactated ringers works in the United States versus Spain. And the people in the United States tend to be a little heftier. And there was a paper by Vijay Singh that suggested it's the calcium in the lactated ringers rather than the lactate that's actually improving outcome in patients that are releasing free fatty acids. So the question is that has anybody looked at those 2 differences, the BMI and the Plasma-Lite, for example, to tease out what's actually beneficial?
Those are both tremendous questions, Dr. Whitcomb. Theoretically, the Plasma-Lite would be very similar to lactated ringers because they're quite similar constituents in those 2. I'm not sure there'd be a huge difference in the 2. I'm not aware of at least a major randomized trial or major prospective trial. I know there's some retrospective stuff looking at Plasma-Lite, I think, and as I believe it was favorable. In regards to Spain and lactated ringers, De Madera, at the 24-hour mark, he didn't see any difference in outcomes, although at the 48 and 72, he did see some improvement with lactated ringers. So there is some interest in Spain as well and the result of it. I think that your point about calcium is excellent, and there's certainly Dr. Singh's paper is very interesting that it could be that part, especially since we see so much increase in calcium signaling in the early phases of acute pancreatitis and the relation of that with pH. One final nuance of that is there was some really nice work, actually from Nevada, where they did see a big increase in lactate in blood levels of those given lactated ringers intravenously. So there is certainly an effect of lactate itself. So it could be an immunologic effect, or we don't really know for sure. It could all just be that it's a better pH modulator versus chloride and doesn't cause some of those bad things that we've seen in ICU and ER literature with sepsis.
Yeah, so the comparison may be able to sort out the effect of chloride versus the effect of lactate. So
difficult, yeah.
Second question is that if in fact the problem in patients that are progressing to multi-organ failure is a breakdown of the endothelial cell barrier, then more crystalloid is not going to help because it will pour out in the interstitial space. Has anybody tried using fresh frozen plasma as well as other fluid in order to increase the oncotic pressure or maintain it in the vascular space during the acute phases that you're aware of?
I'm not aware of it in the acute pancreatitis. I know with trauma literature and some of the surgical literature, I did see use of things like that, or even blood or things like that, comparing other areas. Not
Multi-trauma, it seems to help head injury outcomes for reasons I don't understand.
Dave, there were some randomized trials of hydroxyethyl starch which showed worse mortality than normal saline. And there have been some old trials of fresh frozen, but it was back in the day when we believed we were giving something to neutralize the pancreatic proteases in the fresh frozen as opposed to giving it as a volume support. I had a question maybe for you and Miklos as well about something that James presented, which was looking at the difference in pH and bicarbonate level in the serum with one infusion or the other, and the differences seem modest. And I was just wondering, from the experimental standpoint, are those degree of differences sufficient to be clinically important? I mean,
we have some real experts actually on that. Diraj published a paper on this, and I think Fred Gorlick has also worked on that as well. So I'll let them answer your question to me for me.
Well, definitely Fred can answer from the mechanistic aspects with regard to the role of acidosis in this situation.
Maybe just a quick question to Chris and so it seems that it's becoming common practice that you feed the patient as soon as possible. How much is that based in science? I mean, do we have enough clinical trials to support that, or is it just more like a cultural shift in management?
The question, what's the basic science support for that strategy?
Or clinical.
I think I could say probably across the board there's hardly any basic science support for a lot of what we do in managing these folks. I guess I was thinking that feeding people early is no worse than feeding them late, I guess maybe both are bad. I don't know.
And to comment on the same point, Miklos, I think when we wanted to show if feeds are feasible and actually are not harming the patients, and we proved that through different studies, it becomes almost an ethical issue. How would you randomize the patients to be NPO and feed others? And if you do, and oral feeds are possible, even more ethically, you should not be dropping tubes in people who can eat early. So it's back to that, which IRB is going to approve it? Yeah.
Aleah, Iowa. So I'm going to ask my son, but this question really applies to the whole panel and perhaps the whole symposium. So I'll just tell you about my experience with one of my patients in September when I was on service. So really the importance of pediatric obesity and the diabetes, that's just a big component of the necrotizing pancreatitis. So I had this patient, 16 years old, came in with type 1 diabetes. He weighed 350 pounds. So he couldn't even lay down on the bed straight. And very quickly went into, he had all the criteria for SIRS, and he went into, this, pancreatitis and pancreatic necrosis. His BUN, by the way, was completely normal, and he had, so I couldn't predict from that point of view, but he had pleural effusion, and he was in a lot of pain. I tried my best to, let him eat, but he wouldn't eat. So, he didn't have, the air fluid levels or the bubbles in his CT, but he was spiking temperatures. So we started him on antibiotics. So it's just, can you comment on some of those other factors that, IL-6 is not something that we commonly order as clinicians. And all those other things that are in the pipeline, the proteomics is not something that we have in our armamentarium. But those are the patients that we, increasingly are facing, and they're very sick. They hate you when you tell them about the tube, that they think you're a terrible physician. So, I mean, the care of those patients that are in our practice, that they're going to get pancreatitis, but the care of them, so just give us a few of your wisdom.
Yeah, so the beauty of the data is that what we have collected in the registry, the observational cohort, is really growing, and hopefully it will be a multi-center study with appropriate, planning and funding. Is that the data is there. When we looked at obesity as a marker of severity initially, it was not, because while it was in other studies, for instance, from Asia, it was because the range of weight in the children in the US is really big. So the wide range of weights didn't allow us to see that obesity is a predictor, which anecdotally we know they do worse because of all the other markers that they have from the obesity. So I think this is a factor that is worth studying again. Now, the comorbid conditions are a risk factor for severity, and your patient had already an underlying diabetes and then obesity on top of it. So yeah, it's definitely worth doing. But the beauty of proteomics, plasma-related studies, cytokines, MMPs, is that eventually once we replicate this, and this is what's needed, is that these studies need to hold true through validation. And if they do, they should become a clinically available test once we find the appropriate tool.
For your patient, actually, this is a very good clinical scenario where actually, expertise from Santi and Chris will be helpful. So you have a patient who is evolving into severe pancreatitis, has SIRS, has necrosis. Would you give prophylactic antibiotics to this patient? And if so, what would you start? And if not, why?
So my first comment. Yeah, my first comment would be, it's all fine and dandy to have guidelines, evidence-based, randomized controlled trials. But when you see patients day in and day out, you know that in a large majority of them, you have to use your gut feeling and clinical experience. So you will have this patient. You have not yet developed a wall in the first 7 days, 10 days, whatever, and the patient is deteriorating. Then you have to send the blood cultures and start the patient on antibiotics. Here, actually, the question is semantics. Are they prophylactic antibiotics, or actually are they antibiotics for already early sepsis infection? That's one thing. And second thing is, so you have to start, you have to treat. There's no other, no guidelines, no nothing comes into the picture. You are taking care of the patient, you have to do that. And subsequently, if they deteriorate, that's when probably I would do the rare CT-guided FNA for those people.
Okay.
Right, I mean, in this patient, the CRP, I think, was 50. I mean, it could be because, of the fat inflammation going on, and the white blood cell count was also very high, and the fever were not coming down, and he has a huge belly. So nobody wanted to really intervene, so the decision was to do the antibiotics.
Yeah. And Chris,
anyway, I don't want to take too much of
No, but Chris, would you wait for this patient to want to eat for 3-4 days before you make a decision for giving enteral nutrition?
I think you allow them first, right? Sorry, Chris, if that's you. But if they don't, then that's where you decide to drop a tube.
Yeah, I mean, I would never second guess an experienced clinician. I mean, some of these folks, they don't pass the eyeball test, and they're not going to eat today. They're not going to eat a week from now. They're not going to eat 2 weeks from now. So you would decide, it's never going to work. I mean, but what those criteria are, who knows? But I think you know it when you see it.
Right. Yeah. I mean, in this case, I was the nasty physician saying that you eat or you get the tube usually, and then they start eating magically. So.
I mean, you all don't have to deal with alcohol, but you still have to deal with the obesity epidemic, don't
We
you?
still do on prom season.
Thank you.
Actually, follow up the question regarding the antimicrobials. Are you going to start with antifungal at the same time you decide to treat?
No.
I have two questions or / comments. I'm going to start with Dr. Vega. Now, first of all, thanks everyone for a wonderfully informative session and wonderful talks. Dr. Vega, I was going to ask, I think that antibiotics in the early phase are challenging. I think primarily for 3 reasons. And the first and foremost is exactly what you alluded to. It's very difficult to tell the SIRS apart that's due to pancreatitis versus infection. Number 2, we know that extrapancreatic infections in patients with necrotizing pancreatitis can be as high as 25%. I think the Dutch have shown that. And number 3, often the person making this decision is your resident who's on call overnight, either in the ICU or on the floor, and they feel very uncomfortable not starting antibiotics. So, I just wanted some of your thoughts on that. And the second thing I wanted to bring up was that Dr. Garg's group published a systematic review in Gastro back in 2013, where they looked at the conservative strategy for the management of necrotizing pancreatitis. And I think there were 8 studies that used antibiotics only, and they had about a 64% resolution in terms, without any need to step up to any other treatment or therapy. I know they had a separate 4 studies in which patients received percutaneous drain placements, but I think those were evaluated separately from those patients who only receive antibiotics. So I want your thoughts on that. And for Dr. Forsmark, I wanted to just
Actually, can I answer so that it will be, otherwise, we forget what's the thing. Yeah,
for sure.
So I'm glad you brought out these extremely crucial points. So most important thing is a resident or a fellow uncomfortable starting antibiotics. So it's already done. So you won't go back in the morning and undo it. That's very important point, you brought it out. But the fact that even the most recent Dutch study brought out 40% of infected necrosis can be just treated with antibiotics without even a catheter drainage. But the first paper actually came from my friend Ramesh in Kerala, 4 patients way back. Then Peter Lyer from Germany came with a bigger thing. Then Pramod from Delhi came with a slightly bigger thing, and then came up with the meta-analysis in Gastro. So we all should know that even infected necrosis can be treated. So that's the reason of starting antibiotics and just waiting. But in endoscopically driven centers, Vikesh, you are one of the thinking endoscopies, but when you have a tool like the thing, the moment you have gas and you have the thing, the first thing is to go for the drainage. But maybe 48 hours, probably, if you start antibiotics and see 48, 72 hours and then go for the thing. But extremely important.
Thank you. And Dr. Forsmark, I just wanted to ask you, the AGA came out with guidelines on the management of acute necrotizing pancreatitis, I think that were published last January 2020, just before the pandemic. And one of their best practice points was that in patients with necrotizing pancreatitis, there should be consideration for the institution of early enteral nutrition to prevent infection. So while we may not know mechanistically how that's happening, I just want your thoughts on, how early is early, because I think most of the studies have looked at this happening within 48 hours, which from a practical standpoint often doesn't happen because patients are being transferred, or they may be at one hospital and people sort of forget to do it because they're just so used to the NPO paradigm. The second thing I want to ask you is that I've anecdotally seen that when you start early enteral nutrition, real true enteral nutrition, you often keep patients' albumins up and they don't have as much third spacing. So I wonder whether that might prevent, may retain a little bit more volume in the intravascular compartment, which also then could be beneficial from the standpoint of course, infection and gut barrier breakdown and so forth.
No, I mean, I think the data is quite mixed on early enteral nutrition. The best data we have, obviously, is from the Dutch, and it says it doesn't appear to make that much difference in terms of the outcomes at least they looked at, which was total infections and mortality. But it may have other benefits, and maybe less compartment syndrome, or better renal function, or all those things might theoretically be there. I don't have any objection if people want to start early. I just think the data says it's, at least what we know, 24 hours, it seems to be about the same as 48 and 72, but there may be subtle things within individual patients that are, you're seeing that have not been well studied.
So just echoing Dr. Worshmark's comment, in our large practice at Rochester, we just let patients take, whether they're mild, moderately severe, whatever, in the first 3-4 days, we just let them take whatever they can. And then it's usually day 5, you will know, are they really moderately severe or severe, and do they need tube feeds? Majority of the patients, even with necrotizing pancreatitis, get dismissed in 7-8 days. They may come back later, but they will be eating.
Dr. Purich?
All of you did a very, very good job. And what's interesting is the two of you sitting next to each other are like alpha omega to me. Dr. Toscas, with your group, got me involved in the pancreas and to set up the availability of secretin to do function testing. And that was considered something that was for older people. I've seen you brought up the fact today in a big way that acute pancreatitis
Thank you,
is
I guess.
Yes.
And my question is, about 3 or 4 years ago, when I started to realize, as well as the FDA wanted data on young children, the function testing, we were approached by a group in Florida to start function testing in children. And we started it, but COVID delayed the actual onset of starting it because of the research group was reprioritized, and so it started later. But at the NAPSCAN meeting, what impressed me was that the pancreas, as well as the livers of children, infants, are normally immature, very immature. And it's interesting that you said that acute pancreatitis is prevalent in your group of children that start, I don't know what age that you're talking about. Is that about 3 or 4, 5, up to 17?
So acute pancreatitis in our cohort, we have children as young as 2 years old. Definitely, the younger group has a different set of etiologies, and their presentation is just different than the older school-age kids. They're more like subtle, but they do get acute pancreatitis. But maturation of the enzymes, you're correct, Dr. Purich, it does happen with age. So in less than 2 years old, we showed that through pancreas enzyme activity testing from actual pancreatic juice does mature over time. And there are, different enzymes less than 2 years of age that's still not fully mature.
Okay, and that's the fundamentally the problem with the young infants, where we're weaning them off of formula or milk with diet for the liver. Now, if we have immature pancreases, we probably have immature levels of enzymes developing at different ways. And I was just curious, we're in a process with the WRAP study, as you know. We'll be looking at the genomics and everything at the young group. But what it got me interested just today when you started talking about the acute pancreatitis situation. I thought that was something after 30. Is it possible, is there any relationship between us weaning children off of milk to go on to regular adult food, that we might be causing a problem with the pancreas that has not yet evolved to the point where it was secreting proper amounts of trypsin and other things to handle food? And could we be causing a relationship here, like for failure to thrive, you do have a relationship to the immature. In fact, some places they have been giving pancreolipase type systems to alleviate that. So is it possible that in young children, in the intense effort to switch them onto adult food, that we're also inducing acute pancreatitis incident in the pediatric population, which then ultimately ends up with the problems with the adults?
Yeah, I don't fully know the answer to that, but if I may summarize what I heard, from your points, there's two issues. There is the exocrine pancreatic insufficiency something that is present maybe in the young infants or toddlers or less than 2? Yes, and it's harder to diagnose once they're on human breast milk. I mean, it's easier to manage. They don't need pancreatic enzymes than when they are weaned to oral and more solid feeds. That's when it becomes prevalent, and we don't know why. What's in breast milk that does have some enzyme replacements. But exocrine insufficiency, you would think they should not have risk of acute pancreatitis, but we don't fully know it because they still get risks. Even in the acute, recurrent, and chronic pancreatitis, they get flares, but maybe their enzyme elevations are not as dramatic, the lipase and amylase. But acute pancreatitis does cause exocrine problems. So it's, which one is the chicken and the egg? I wouldn't be able to tell.
Okay, well, that was my main point. I'd just like to make one point to everyone, is that our major emphasis from now on, for a while now, will be in the pediatric area to establish the relationships of normal function as well as abnormal function.
Thank you very much.
So if you have
Yes.
any studies that you want funded, please approach us.
Thank you.
Thank you,
Ed.
Dr. Purit. So we are right on time. We want to thank the speakers for excellent talks and for your participation. And with that, we'll adjourn the session. Thank you.